Good morning, everyone, and welcome to May Grand Rounds. I'd like to start with a land acknowledgement that we acknowledge that we are on the traditional lands of the first people of Seattle, the Duwamish people, past and present, and that we honor with gratitude the land itself and also the Duwamish tribe. And we acknowledge that this does not take place of authentic relationships with Indigenous communities, but does serve as one way to honor the land we're on and to resist cultural erasure. We also acknowledge that this country exists and prospers as a result of free enslaved labor of Black people. And we honor the legacy of the African diaspora and Black life. We honor Black skills and knowledge that have been stolen due to violence and systemic oppression. We affirm our commitment to be aware of our own privilege and to be aware of oppression and how that plays a role in the lives not only of our patients and families, but also of employees here at Seattle Children's and in the community. We strive to be an anti-racist organization and group, and we also strive to improve patient care for people with less privilege. I do want to alert people that May is Mental Health Month, and that next week, May 7th through the 11th, is Children's or Youth Mental Health Acceptance Week within Mental Health Awareness Month. In addition, May is Asian American and Pacific Islander Heritage Month, and we celebrate that. And it's also Jewish American Heritage Month, and we celebrate that as well. So we have a lot to celebrate this month. And next week is Nurse Week, and we appreciate the nurses who work in our system and in our community. So I do thank all of you for coming to Grand Rounds for May. And I want to introduce Dr. Zuloff McCurdy. Dr. Zuloff McCurdy is a faculty member in our department, and she is going to introduce our Grand Round speaker today.
Morning, everyone. It's my great pleasure to introduce Dr. Amy Yule, who will be sharing her expertise on how we can support youth with substance use disorder. Dr. Yule is an assistant professor at Boston University School of Medicine. She's the vice chair of addiction psychiatry at Boston Medical Center. She's a consultant with the Department of Psychiatry at Massachusetts General Hospital and a part-time lecturer at Harvard Medical School. She completed her medical degree at UCLA before coming out to Boston, where she completed an adult and child psychiatry training at Mass General Hospital in McLean, as well as addiction psychiatry training through the Partners Healthcare Program. She's been the recipient of several grants, including funding through the National Institute on Drug Abuse and the American Academy of Child and Adolescent Psychiatry. She's currently a multiple PI on a study that's evaluating the effects of behavioral health treatments for youth with psychiatric disorders and reducing the risk of opioid use disorder. Dr. Yule also provides clinical care to children and families with substance use disorder in a community multidisciplinary outpatient clinic. I'm fortunate to cross paths with Dr. Amy Yule at her time at Mass General Hospital, and I'm so excited for her to be here today because it's really important for us to be advocating for this population in both our research and clinical practice. So please welcome Dr. Amy Yule.
Thank you for the opportunity to be here. I'm excited to talk about youth with substance use disorders with a focus on prevention, risky behaviors, and treatment. Before we get started, I wanted to note my disclosures, which include some of my clinical activities and sources of funding for my research work. So today we're going to briefly touch upon the prevalence of substance use among youth, then switch gears to talking about psychiatric and substance use disorder comorbidity with a focus on opportunities for prevention. Later, talk about risky behaviors, including overdose, and then end by talking about treatment of co-occurring psychiatric disorders and substance use disorders. So I think it's important to talk about the prevalence of substance use in adolescents because popular culture and popular media really normalizes substance use, and that's actually not accurate. And so this is data from the Monitoring the Future study showing you past year use among adolescents with use among 8th graders in blue, 10th graders in orange, 12th graders in gray. And you can see that clearly not all adolescents are using substances, and about 52% have used alcohol in the past year, 33% have used an illicit drug over the past year, with the majority of illicit drug use being cannabis use, and then misuse of prescription medications, cocaine and heroin use being much less common. Since 2016 with FDA regulation, we've seen a slight, definitely have seen a decrease, but still quite a few high school students are using e-cigarettes with nicotine in them. And the concern is that these devices aerosolized liquid that does contain nicotine in it, and it's a high concentration of nicotine. And so if you use these devices, you're at greater risk of becoming dependent on the nicotine and developing a nicotine use disorder. And then the other issue is that they're not just vaping nicotine, they're also vaping cannabis. And so this is data from the Monitoring the Future that shows you past month vaping of THC. And you can see between 2018 and 2019 that the number of number of 12th graders who vape THC doubled from 7% to 14%. And the concern around THC vaping is that what you vape has a much higher percentage of THC. And so the cannabis, the kind of plant, the marijuana plant, has generally a THC percentage of around 12 to 16%. And kind of what's in these kind of cartridge devices that kids are vaping, that can have upwards of 75% THC content. And what we know is that your risk of adverse effects associated with cannabis exposure increase with a higher percentage of THC. And so if you're using a cannabis product with a higher THC percentage, you're at greater risk of having symptoms of paranoia, acute anxiety, developing cannabis hyperemesis syndrome. And so it's not a minor thing that adolescents in particular are really transitioning to vaping commonly vaping instead of necessarily using the plant. And this has become a big problem in high schools. So kids like to vape because they get high really quickly, but also they can kind of easily hide these devices. And then they also don't smell like marijuana. And so it's often harder for school administrators and parents to kind of detect that a kid might be using cannabis. So the other thing to be thinking about is we've been talking about substance use, and substance use patterns are on a continuum. And so as we continue in the talk, I'm going to switch to talking about substance use disorders. And to remind you, the criteria we use to diagnose a substance use disorder among adolescents is the same as for adults. And so we look at 11 criteria over the past year and look for problems associated with use in those different domains. And if someone has at least 2 of those criteria, that meets criteria for substance use disorder mild. If they have 6 or more criteria, they meet criteria for a severe substance use disorder. And the reason why I think this is really important to be talking about with behavioral health clinicians is that our kids are at greater risk. And so we know that if you have a psychiatric disorder in childhood, you're at increased risk to develop a substance use disorder. And so this is data from a meta-analysis showing you the odds ratios associated with different disorders and risk of a substance use disorder. And to remind you, if an odds ratio is above 1, that means you're at increased risk. And so you can see that kids with ADHD are at 2.5 times greater risk to develop a substance use disorder relative to kids who do not have ADHD. Likewise, kids with oppositional defiant disorder or conduct disorder are at 5 times greater risk to develop a substance use disorder than those who don't have conduct disorder. The increased risk was statistically significant for ADHD, depression, conduct disorder. It wasn't for anxiety, although it does kind of cross the threshold of being above 1. And that's likely because childhood anxiety disorders are very heterogeneous. And so, we do know that PTSD is associated with an increased risk, but specific phobias or separation anxiety may not be associated with such great risk. So the other thing is that we know that why this is important for behavioral health clinicians, that the kids with, that we see a higher prevalence of substance use disorders among adolescents with a psychiatric disorder. And so this is showing you the prevalence of drug use disorder in alcohol use disorders among those with a psychiatric disorder and those without a psychiatric disorder. And so you see the orange lines that there's a much greater percentage among kids with a psychiatric disorder in terms of the prevalence of a substance use disorder. The other thing to be kind of noticing is that we see the drug use disorders are more common than alcohol use disorders when we look at adolescents. And so you may remember at the beginning that alcohol use is more common than drug use. But when we look at kids with a use disorder, we do see that drug use disorders are more common. And this is largely cannabis use disorders. So now we're going to kind of switch and think about opportunities for prevention before we get into kind of risky behaviors and treatment. And do think that there are opportunities for prevention, given that we know that this high comorbidity exists between psychiatric disorders and substance use disorders. And so as we think about kind of why do we see this high comorbidity, it's definitely multifactorial. And one issue is that each disorder can increase the risk for the other disorder. And so a piece of that is that if you have psychiatric symptoms that are untreated, some adolescents or kids do cope with those symptoms by using substance use. And then we do see that individuals with heavy substance use do experience psychiatric symptoms related to the heavy substance use associated with acute intoxication and with withdrawal symptoms. So another reason that these two disorders we might see a high comorbidity is that there might be a familial relationship. And so these disorders might run in families. And I'm going to talk about some of our work looking at the relationship between ADHD and substance use disorders in the next few slides. And so we know that there's high comorbidity between ADHD and substance use disorders. We also know that ADHD is a familial disorder. We know that substance use disorders are familial disorder. And so our group asked the question, is there a relationship between the two disorders and families? And the way that you look at this relationship is with a familial risk analysis. And this is where you analyze whether the relatives of an individual with a disorder have a higher likelihood of having the disorder than relatives of people without the disorder. And the individual who brings the family to the study is referred to as the proband. I had the kind of opportunity and the privilege of having access to a large data set of boys and girls with ADHD through the MGH Psychopharm group. And so we ended up having 400 probands. And within those, when you look at two disorders, you need to end up having 4 different groups. So you need probands with ADHD only, probands who have a substance use disorder only, probands who have both, and then individuals who don't have ADHD and don't have a substance use disorder, to end up looking at the prevalence of the substance use disorders in relatives and seeing if there's a pattern. And so fortunately we had 400 boys and girls, probands, and kind of we followed them to the age of 21, and so ended up with 4 different groups, and then had 1,300 relatives that include their siblings and their parents. And so we used Cox proportion hazard models to analyze the data. And right here, you're looking at survival curves. And you can see, this is looking at the lifetime prevalence of a substance use disorder in these relatives in these different groups. And so you can see that there's 3 lines that are higher, which means a higher prevalence of a substance use disorder. And then that blue line, which is a little bit lower. So the blue line is the prevalence of a substance use disorder among relatives of the control group who didn't have ADHD or a substance use disorder. And then as you look at the lines above, you do see that relatives of individuals who had a substance use disorder are in the red line. So there's a high prevalence of substance use disorder in that group, so not surprising. Likewise, the orange line are those relatives of the individuals who had ADHD and a substance use disorder. So again, not surprising that you're seeing a higher prevalence of substance use disorder in that group. And then the surprise was the green line. And so that's the prevalence of the risk of a substance use disorder among relatives of an individual with ADHD only. And so we saw that these are kind of the graph put into numbers in the hazard ratio, which is similar to an odds ratio. And so when you compare the relatives of individuals with ADHD are 1.4 times more likely to have a substance use disorder when compared to relatives of individuals who did not have ADHD or did not have a substance use disorder. So there's something about, ADHD, and this kind of runs in these families along with substance use disorders. We also looked at the presence of assortative mating and co-segregation. And assortative mating is the tendency for patients with the same disorder to marry a spouse who has the same disorder. And so we didn't see any evidence of assortative mating, but did see co-segregation present. And that's where 2 disorders have closely linked genes that are inherited together. So co-segregation in the absence of assortative mating suggests that there's a specific familial relationship between ADHD and substance use disorders. And so if we put that all together, what we find is that there are various pathways involved in the transmission of substance use disorders in ADHD families, and that there's this familial relationship between the 2 disorders. So what does that mean clinically? Often we're really focused on the child coming into the office with the disorder, and just want to encourage us to be thinking about the whole family. And that when you have a child with ADHD, it's important that parents know that that sibling is also, not only is the child with ADHD at increased risk for a substance use disorder, but their siblings at increased risk for substance use disorder. And so really want to be thinking about screening for substance use within these families, and making sure that parents and families are aware of this risk. And so in terms of thinking about substance use disorder prevention opportunities within behavioral health, kind of talked about screening. And then there's the question of treatment. So how does treatment impact, how does treating psychopathology impact someone's risk of developing a substance use disorder? And we recently did a systematic review and found that most of this work has really been done around ADHD, and that there's somewhere of 22 studies that have been published looking at this relationship and are looking at treating ADHD with medication and someone's risk of developing a substance use disorder. And there's a fairly clear signal that treating ADHD does increase someone's risk of developing a substance use disorder. But we only found 6 other studies for other disorders. There's quite a few different disorders, right, that we could be thinking about. So did find a handful of studies looking at depression, bipolar disorder, and psychosis with some mixed results. And so feel really fortunate to have gotten funding along with my mentor, Dr. Timothy Willens, to look at this relationship and look at the impact of treating psychopathology on among kids with who are in behavioral health care, and looking at treatment and how it impacts their risk of developing a substance use disorder through the Helping End Addiction Long-Term Initiative. And you guys are lucky to have another group as part of this prevention cooperative here at Seattle with Dr. Ahrens and Dr. Haggerty. And so excited to hopefully have results to share with you maybe later in a couple of years. So now we're going to switch gears and think about risky behaviors in youth with substance use disorders. We want to try to keep them safe, and know that substance use disorders are associated with significant morbidity and mortality, including increased risk of suicide, of violence, complications associated with acute and chronic medical illness due to substance use disorders, and overdose. And often we don't want to think about bad things happening to young kids, right? But, have had, as I'll talk about later, a number of overdoses in my clinical practice, have had to be the one diagnosing a 17, 18-year-old with acute hepatitis C. And so these things do happen to kids, and we need to be kind of thinking about what are unique risk factors for youth relative to adults. And as we talk a little bit more about overdose, I want to also remind people that when we use the term overdose, people often think about opiate overdose. But an overdose, if we take a step back and think more generally about this term, an overdose is the ingestion of an excessive amount of a substance. And so you can have an overdose on many different substances, not only opiates. But when you do take an excessive amount of a sedating substance, you are at high risk for death. And when you take a sedating substance, it can be fatal. The overdose can be fatal when it's associated with an impaired level of consciousness, respiratory failure, and people stop breathing. And so do want to be thinking about opiates, alcohol, benzodiazepines as we think about overdoses, and particularly as we think about youth. And as I said, it's hard to think about bad things happening to kids, but we are seeing overdose deaths in youth. And between 2020 and 2021 saw a disproportionately higher increase in the number of drug overdose deaths among adolescents ages 14 to 18. So 14 to 18-year-olds. There was an increase in 20% relative to 11.5% in the overall population. And when they looked at the drug overdose deaths by substance, really do see that this is being driven by fentanyl exposure. And this is both known fentanyl exposure among adolescents that are misusing opiates and know that that the opiates they're using might have fentanyl, and then also unknown fentanyl exposure. So kids who are using this press pill, they think it's Adderall, they think it's alprazolam, and it turns out to be powder with fentanyl. And as we look at kind of different groups by race, ethnicity in terms of who's been more impacted by these drug overdose deaths among adolescents, really do see that from 2016 onwards, that American Indians and Alaskan Natives have been disproportionately impacted by these drug overdose deaths. And so, going from and that particularly between 2020 to 2021, that the death rate per 100,000 jumped from 8 to 12. So this is a population we really need to be thinking about in terms of overdose prevention, and encouraging them and supporting them in terms of accessing treatment. So, as we think about kind of what do we do in the face of these increasing drug overdoses? One thing we can do is really think about what are risk factors for drug overdose in youth that are youth specific. And I became more interested in this topic in 2014, 2015, when we started to see when I had an increase in drug overdose deaths in my clinical practice, which did correspond to around when fentanyl became more part of the drug supply in Boston. And so we did a systematic review to try to see kind of what risk factors are specific to youth. And found that there wasn't a lot of literature out there, but did find as we think about risk factors for youth, some of the ones that are some risk factors for drug overdose for adults do also apply for youth, like injection drug use, opiate misuse, benzodiazepine misuse, polysubstance use, and then that they kind of in incarceration, unstable housing. Witnessing overdose was a risk factor at the time when we did this literature review that seemed to be youth specific. We didn't kind of see as much written about that in the adult literature. And then interestingly, there was nothing about medical risk factors. And so for adults, we do know that having chronic pain or other medical comorbidities increases your risk of overdose. But this at the time hadn't been looked at all for youth. And then there was some literature about having a history of psychopathology increasing risk for youth and for adults, but not a lot there in terms of information we could find that was youth specific. And so as a child psychiatrist, we decided to focus on that and to look at this among the youth that we were treating at Mass General Hospital. And so in our clinic that was treating youth between the ages of 14 to 26 with a substance use disorder, we decided to look at among these youth seeking treatment, what's the prevalence of overdose? And then, look to try to characterize substance and psychiatric risk factors associated with overdose. Did this through a systematic review of our medical record. We were fortunate to have a very structured and standardized template that our clinicians were very consistent about completing. And so started the chart review in 2012, which was the point which was when we had a kind of change in the template, and ended up kind of looking at between 2012 and 2013, and did that in parts that we would have a follow-up period to look at as well. And so we kind of looked at kids coming in for an evaluation and looked at their history of overdose, and then also looked at overdoses after receiving treatment. And in terms of how we defined overdose, we were pretty broad and defined unintentional overdose as any documentation of overdose where there was a significant impairment in level of consciousness, and then also included intentional overdoses where there was a substance ingestion reported as a suicide attempt, and that could be an ingestion of illicit drugs or an overdose with medication, but again kept this fairly broad to be kind of looking for information to try to help we could use clinically to help try to keep our kids safe. And so who was this group that we ended up looking at this within? And so we had 200 patients. Their mean age was age 20. They were largely male and largely Caucasian. In terms of their substance use disorder characteristics, this is looking at lifetime substance use disorder characteristics. And so there was a high prevalence of alcohol use disorders, cannabis use disorders. 38% of the sample had a lifetime history of an opiate use disorder. Many of them had a history of adverse effects of substance use. So 68% had a history of a blackout. Kids often minimize blackouts, but I think it's important for us to remember that it's impacting their brain so much that they don't remember what happened. And so it's not a benign event for their brain. And then, did have 17% that had a history of intravenous drug use and 23% with a history of needing to go to inpatient detox. In terms of their psychiatric characteristics, there was not surprisingly a high degree of psychiatric comorbidity. So 86% of the sample had a lifetime history of a psychiatric diagnosis, with ADHD and anxiety disorders being very common, along with major depressive disorder at 44%. Eating disorders, there was 7.5% of the sample had an eating disorder, which included both eating disorder not otherwise specified, but also anorexia and bulimia. And then about 22% had a history of psychiatric hospitalization. 29% had a history of self-injurious behavior, which is largely cutting. So what did we find? We found that many of them had a history of an overdose. So 29% had a history of an overdose, when we were evaluating them at an initial evaluation. When we looked at the intentionality of the overdose, they were largely unintentional overdoses, but 31% had a history of an intentional overdose, and 7% had a history of both. And then we looked at kind of what were the strongest clinical characteristics associated with a history of overdose by doing a multivariate analysis, and found that the things that were significant were having an alcohol use disorder increased your risk of, or was associated with having a history of overdose with an odds ratio of 2.6. Having a history of blackout. So again, as we think about kind of overdose, is an ingestion of an excessive amount of a substance. It's not surprising that the blackouts tracked with having a history of an overdose. And then having a history of intravenous drug use was also associated with having a history of overdose, which kind of mirrors what we found in the literature. We also found that having a history of a psychiatric hospitalization, so kind of more severe psychopathology, was associated with having a history of an overdose. And then eating disorders were associated with having a history of an overdose with an odds ratio of 5. So that was kind of surprising, but interesting to find. And then, as I said, we, again, kids came in for evaluation. We looked at having a history of overdose and then looked at what happened over time in terms of treatment. And so looked at kids that engaged in care. And out of those initial 200, 127 of them did come back for 2 appointments in the 30 days following their initial evaluation. So quite a few engaged in care. Over what ended up being about a 2-year period, there were 10 non-fatal overdoses among the kids that engaged in care and received treatment among those initial 200. At the same time that we were doing this, we're really concerned about overdoses, and so did also have the same kind of systematically collected information about a group of kids that were kind of seen before we started this, the chart review, and then kind of after, weren't part of that initial 200, and had, 9 of them with a history of, who had a fatal overdose. And so did include those with a non-fatal group to have a little bit of a larger overdose group. So ended up with 117 with no history with no overdose after treatment, and then 19 who had an overdose after treatment. And when we look, so that ended up being a prevalence in terms of that initial 200 of 8% of kids had a non-fatal overdose after receiving treatment. And we did find that 50% of them had that non-fatal overdose while they were in treatment. And then 80% of them kind of continued in treatment after having the non-fatal overdose. So for some kids, they'd fallen out of care and then did 3% for substance use treatment, which is positive. And then largely those non-fatal overdoses were non-intentional. In terms of fatal overdoses, we were often finding these out from families who were in quite a bit of distress, calling us about their child's death, or also from kind of emergency room physicians. But so we really didn't know kind of the intentionality of these fatal overdose deaths. Also didn't know kind of what substances were involved. But we did know that all the kids that had a fatal overdose did have a lifetime history of an opiate use disorder. And so, given the timing of these overdose deaths and the fact that they had an opiate use disorder, it's, probably pretty likely that the fentanyl or that these are opiate involved overdose deaths, but we don't know for sure. And then when we looked at the strongest clinical predictors of overdose after receiving treatment, history of intravenous drug use was the big factor, and that's and we know a huge risk factor for adults. So not terribly surprising that we also saw that for kids. And then mood disorder, kids with mood disorder not otherwise specified. So a lot of emotional dysregulation that was associated with having an overdose after receiving treatment. So kind of are seeing kind of links between, some of the similar risk factors in adults for kids as we think about substance use patterns, but then also this marker of more severe psychopathology being a risk factor for the youth in our program. And then we saw a little bit of a steady signal, and this is a little bit of a stretch, so bear with me. But, when these kids are coming in for an evaluation, they were average age of about 20. We did see that the mean age of first overdose was 18 years. And knew that kind of came in for an evaluation, 29% of the group had a lifetime history of an overdose, and then had 8% that had an overdose after receiving treatment. And that kind of window that we were looking at ended up being about 2.5 years. And so this is going to stretch. This was not what we were kind of initially designed to do with the study. But it seems like there's maybe a signal that treatment is decreasing overdose risk, which is good and to be expected. But as we think about that, kind of for whom is this decreasing their risk? And so I think that's still an unanswered question. But as kind of when I do this work, I'm much more kind of vigilant as we think about these kids with more severe psychopathology. So the ones with history of psychiatric hospitalizations, a lot of mood dysregulation, as those being kind of two important markers to be thinking about. So with that, we're going to switch to talking more about treatment among kind of youth with substance use disorders. And so what does adolescent substance use disorder treatment look like? We have some experts in the audience, but as we think about adolescent substance use disorder treatment, the kind of main components do include medication, both for the psychiatric disorder and for their substance use disorder. Medications for substance use disorder are really underutilized for adolescents. And it's, as child psychiatrists, we often prescribe a lot off-label, but for some reason, when we get to thinking about medications for substance use disorders, despite tremendous morbidity, people have a really hard time thinking about kind of off-label medication use for adolescents with substance use disorders, but would encourage people to kind of think through this. We talk about risk benefits in the same way with kids for substance use disorders is the same way that we do for kind of other medications we might be prescribing for other conditions. Therapy is really important for adolescents with substance use disorders and is really the gold standard in terms of treatment. Family involvement is key. They are incredible partners. You do need to be kind of really mindful of how you involve them to maintain the adolescent's trust and confidentiality, but family is really important. And then peer support is also really important. And I was telling people this morning and at dinner last night, you have a wonderful recovery high school here in Seattle. And when we had the child psychiatry meeting here a few years ago, we showed a documentary about recovery high schools, and one of the social workers and the kids from the school came and were part of that presentation, and their voices were so impactful. And so these are really wonderful kids, and they do need peer support, and that's a key component that we see of what helps kids be successful who are engaged in recovery high schools. And then just want to highlight that it takes a team, and it's important to stay flexible. So we, often as clinicians, we're really worried about these kids. We want them to kind of engage in everything if possible, but they may not want to engage in everything. Their parents may not be ready to engage. And so important to stay flexible and kind of listen to, stay patient and family-centered as well. So the sad news or the bad news is that most adolescents with a substance use disorder do not receive treatment. And this is even, so you may say like, oh, they're just out there in the world kind of doing their thing. But we find this even with adolescents with co-occurring psychiatric conditions. And so this is data from the National Survey of Drug Use and Health, looking at annual treatment of adolescents who have depression and a substance use disorder. And you can see that these kids, nearly half of these kids are getting treatment, but they're only being treated for their depression. And so the gray line that's at the top, or kind of dark blue, is, kids, adolescents who have depression and a substance use disorder, who receive treatment for their depression only. And then way at the bottom, the orange line are kids that are receiving treatment for both their depression and the substance use disorder. And then the blue line that's barely kind of there are kids who receive treatment for their substance use disorder only. So these kids are coming and receiving treatment for their depression, but their substance use disorder for some reason is not being addressed as part of their care. And as we think about like, why don't adolescents receive substance use disorder treatment? Definitely also multifactorial. There can be difficulties with finding treatment. And I think we were talking about that at dinner last night, that even in Boston, where we have three academic medical centers with substance use disorder specialty care, we see still tremendous difficulty in terms of finding providers and finding services for these kids, particularly outside of the city of Boston. So that's a big issue that's contributing to the fact that of why many adolescents with a substance use disorder don't receive treatment. But things like stigma, that's also still a really big issue. Stigma for substance use disorders that the parents experience that make them hesitant to talk about the fact that this is going on, and then stigma for kids themselves as well. Sometimes the adolescent doesn't want to go to treatment, and so that is one of the reasons they don't get treatment. And then sometimes the substance use is not identified as a problem, and so that's where you come in, and that kind of we really need to be more systematic in screening and identifying this as a problem, and trying to work together to treat both disorders. And as we think about treating co-occurring disorders, we want to really have the message of there's no wrong door. So, parents and kids don't read the manual of like where they're supposed to go for treatment, right? And so knowing that there's tremendous stigma, if they're coming to you and maybe you feel like you'd really like them to be seeing your substance use disorder colleagues, but they're not ready to get there yet. Really want to be supporting them where they're showing up for care and trying to address both disorders using integrated treatment for both disorders. And there's a lot of commonalities between both disorders. So even if you don't feel as confident in your knowledge of substance use disorders, when we think about relapse prevention for depression, it's similar things to relapse prevention for substance use disorders. As we think about interventions for depression, the importance of like structure and behavioral scheduling, same thing goes for substance use disorders. And so there's a lot that you can do within kind of your care in the care setting that you're in. So I think I've belabored this point that integrated treatment is really hard to find. So, and so as we think about medication in particular for co-occurring psychiatric and substance use disorders, I talked about this earlier, but really want people to be considering medications to treat both the psychiatric disorder and the substance use disorder. Maybe kids and parents aren't ready for a medication to treat the substance use disorder, but really helpful that they know that these medications exist so that maybe 6 months to a year when they maybe aren't in treatment with you, they know that, oh, wait, I'm really having a hard time getting control of my substance use. They have the knowledge that there are medications that can be helpful. Emphasize the importance of adherence and taking your medications exactly as prescribed. So this is probably what I do for 80% of my appointments is kind of talk to kids about like, how are they taking their medications? Often they're not taking their medications. Sometimes they're not taking quite as prescribed. And so I often will see them frequently for follow-up, especially given their morbidity that does exist with having both disorders. And we'll often be prescribing smaller quantities of medication so that if they don't take it exactly as prescribed and maybe take more than prescribed, that there's less risk. And then I'm also really mindful of the fact that they may not be ready to stop their substance use. And I need to be thinking about interactions between the medication they're taking and the substances they might be ingesting. And along those lines, was finding whenever I was out of the office that one group of patients who often were particularly struggling were kids with bipolar disorder or substance use disorders. So whenever I would go out of the office and sign out the kids that had been in the emergency room in the hospital, recently arrested, they were often kids with bipolar disorder and a substance use disorder. And so that made me kind of more curious about what do we know about medication treatment for this patient population. And so as we kind of think about medication treatment for youth with bipolar disorder and a substance use disorder, there's actually been only one randomized controlled trial published to date for that patient population, and it was with lithium. And so lithium is a very good medication for treating bipolar disorder, both for kids and for adults. But there are, some concerns about this very narrow therapeutic window. And particularly if kids are over ingesting substances and getting dehydrated or vomiting. So what did we find with this study? We did find that, they found that kids that were randomized to lithium, there was no difference between the kids on lithium versus those on placebo in terms of their mood symptoms, but did see a greater improvement in substance use on lithium. And so the dotted line on the top are % urine toxicology tests that were positive. And so higher is better. That means that kind of you had more, higher is worse, sorry. So that means you had more toxicology tests that were positive, and lower is better. And so the lithium group is that lower line. And then also did see greater improvement in functioning for kids that were on lithium versus placebo. And so, this is looking at their global assessment of functioning score, and the solid line higher is better. The solid line are those kids that were on lithium. And so, do have a kind of a signal that medication treatment can be very impactful for this high risk group. But the tricky part, clinically is personally concerns about their adherence to lithium and kind of risk of dehydration and the narrow therapeutic index. And so with funding from the American Academy of Child and Adolescent Psychiatry, as well as NIDA, I was kind of optimistic that I could try to look at this question of what makes sense in terms of medication for these kids, using an atypical antipsychotic medication that we commonly use to treat bipolar disorder in kids. So did design and conduct in a randomized controlled trial looking at the effect of quetiapine versus placebo over 8 weeks. And so kids came into the study and they could continue the medications they were on, and then be titrated over the first 4 weeks up to kind of as tolerated, but they could tolerate, but up to 300 milligrams of quetiapine, and then stayed on that whatever dose they stabilized at for the subsequent 4 weeks. And our kind of aims are pretty simple, looking at substance use disorder outcomes and then bipolar disorder outcomes. In terms of the sample we recruited, it was a very, very humbling experience. And so, we were able to get 19 kids into the study and randomized to medication. They were average age of 20, 63% female, 63% white. Didn't see any statistically significant differences in demographic characteristics between the two groups. In terms of baseline clinical characteristics, most of them were using cannabis or had a cannabis use disorder. They were using at least 50% of the days over the past month, with we did see a kind of higher prevalence of substance use among the individuals randomized to quetiapine. They were pretty moody. And so, their Young Mania Rating Scale, which looks at symptoms of mania, ranged from 14 to 18, with a kind of kids in the quetiapine group having more symptoms of mania. And then they also had moderate symptoms of depression with a BDI of 25. And then they weren't doing great in terms of their functioning. So had kind of an average functioning on the global assessment of a functioning scale of 55. And then as we kind of looked at, what dose did they stabilize on, the average dose of quetiapine for those randomized to quetiapine was 150 milligrams. So what did we find? We didn't find a difference for substance use. So the orange lines are kids on quetiapine and the blue line are kids on placebo. And this is looking at proportion of days with substance use at the different study visits, and really didn't see a difference in the proportion of past 28-day substance use between the two different groups. We also saw no difference with severity of cravings or in the proportion of negative urine toxicology screens. In terms of mood symptoms, though, we did see a statistically significant difference between the group treated with quetiapine versus placebo. So this is looking at the mean Young Mania Rating Scale total score over the study from baseline to week 8. And the blue line is the group that was randomized to quetiapine. And so you do see that they go from around a score of 18 to about 8, which, I do think that's kind of statistically and clinically significant. And so, but we didn't see any symptoms between the two groups in terms of depression between those on quetiapine and those on placebo. And then we also saw a signal of improved functioning for kids that were on quetiapine. And so this is looking at their global assessment of functioning score. The blue line are the kids on quetiapine, the green line are those on placebo, and do see that their GAF score for those on quetiapine improves to around 66. So as we kind of think about the study, it was limited by a very small sample size. I'm not optimistic that we're going to be able to recruit a lot of kids for a randomized controlled trial. And so I do think that we need to be thinking about these larger kind of health record databases as we try to kind of think about, get more data to look at what are effective medication treatments for this patient population. However, did with a small sample size still see that treatment with quetiapine led to greater improvement in symptoms of mania and overall functioning. And as we think about these kids coming into clinic, I do think that this is clinically significant in that they're pretty irritable when they come into clinic, and that can be hard. It can, create barriers in terms of engaging in care. And so do you think that if we can kind of quickly stabilize them on medication and decrease the symptoms of mania, it might help them be more successful in staying engaged in treatment and lead to improved outcomes over time. So as we think about general considerations when treating youth with substance use disorders, I mentioned this earlier, but just so important to stay patient and family-centered with the overall goal is trying to get them to come back. It doesn't mean that you don't talk about their substance use if they don't want to talk about it. But, again, just trying to stay patient-centered, focus on what's bringing them to treatment. And then, so you think about what's bringing them to treatment, think about talking about their substance use in terms of whatever brought them to treatment. So if they're concerned about their sleep difficulties, you can provide kind of information about how their substance use might be impacting their sleep difficulties as you're working to engage them. So again, it doesn't mean that you don't talk about the substance use, but just want to stay patient-centered. And then it's important to remember that patients and caregivers can have waxing and waning motivation to change. And so, you can get excited when a youth comes in and is more motivated to make a change, but to not get discouraged if the next time you see them, they're less motivated and, seems like that other visit never happened. And then as we think about adolescents who aren't ready to engage in substance use disorder treatment, it's really important to still support their caregivers because caregivers are really key to getting kids to engage in treatment. And we want them to engage in treatment earlier before they develop before they start using intravenous drugs or develop hepatitis C. And so again, caregivers and parents and families are really important. And so just wanted to mention, it can be hard to find clinicians who are trained in some of these protocols, but there is a book that describes the community reinforcement and family training protocol that's really targeted to caregivers to help them motivate an adolescent to engage in treatment, and focuses on rewarding positive change and having kind of being clear about consequences. So sometimes parents can be really reactive and be like, if you use substances, you can't live here anymore or whatnot. But that's not not a good kind of goal to say because the parents aren't actually going to kick them out. So you want to be more kind of consistent with whatever the negative consequence is, and also make sure that the negative consequence is developmentally appropriate. So it wouldn't be appropriate for parents to be kicking their child out of the house. So it kind of helps with kind of to think about those things and helps in terms of building communication and problem solving skills. Another resource to be aware of is something that my colleague at Boston Medical Center recently has been working on, and then just published a book recently called The School of Hard Talks. And this is, she has an intervention that teaches motivational interviewing to loved ones, and has a free online course that's both in English and Spanish with these interactive e-lessons that are pretty easy to get through. And then again, recently did publish this book. So I think the other thing to be thinking about kind of with these kids who may or may not want to engage in substance use disorder treatment is, and kids who don't have a substance use disorder, is to provide really clear guidance around medications and, kind of guidance. Take your medication as prescribed, don't share your medication. Kids are, especially when they go to college, asked to share their Adderall or, kind of other medications. And kids want to be nice, and it's hard to kind of know what to do when you're asked that. And so important to, especially for kids that are prescribed medications with a risk for misuse, to role play with them and talk to them about the fact that sometimes people may want you to share your medication. And so how are you going to respond if asked about this? The other piece is to be really thinking about safe medication storage and then kind of helping parents and families to get rid of unused medication. So they don't need to save that little bit of oxycodone that they got prescribed for another time when they have acute pain. If they have acute pain that's so bad that they need oxycodone, they should be medically evaluated. So you shouldn't be using the oxycodone that you saved from a different procedure. And then I think, with this evolving opiate crisis, we're really in the fourth wave of the opiate crisis. It's been very dynamic and keeps changing, and I think will continue to change. And so, just want to be thinking about intentional and unintentional exposure to fentanyl. And so, one thing that's important for kids to get the message that they shouldn't use alone. If they are misusing substances, to try to get them to be using with other people, so that someone does have an overdose, there's somebody there that can call for help. But do have a lot of youth with psychiatric symptoms who are in their room, drinking heavily by themselves, in their room misusing prescription opiates. And it's hard to get them to use around other people. And so there is recently resources have been developed because we know that using alone is a huge risk factor for overdose death. Resources have been put into having these phone lines that are kind of where you can call and somebody either takes your information and calls you back within a certain set amount of time based on whatever you're using, or they just stay on the line with you and then kind of just make sure that you remain responsive over time. That being said, I don't know that I've gotten kids to use this line. So I think we have to, this is something that adults are interested in doing who are kind of, I think a little bit more able to kind of recognize risk and that they're not invincible. But in terms of the kids I work with, I don't think anyone's used it yet. So I do talk about it, but we still have a ways to go to, I think, thinking about as we have interventions that help decrease risk, we need to make sure that we're developing adolescent-specific adaptations of those interventions. And then do want to just highlight Dr. Ahrens, who's in the audience, who, as we think about our Heal Prevention Cooperative, has been a huge champion for us to be, thinking as for this, we have 10 sites across the country, and we've been collecting data on overdose, and she's helping us to really think about kind of what the data is telling us and to help guide us in terms of developing interventions to keep these kids safe. Additionally, with this, unintentional exposure to fentanyl, really important to be discussing naloxone with everyone. So it used to be I only talked about naloxone with kids who had an opiate use disorder or were misusing opiates or were using cocaine, given that fentanyl has been in the cocaine supply in Boston for so long. With this, again, evolving crisis, have really switched to talking about naloxone with everyone. And this is an easier conversation with kids. I think we were also talking about this at dinner about kind of kids are kind of really receptive to this information. I think aware of some of this risk. It's a harder conversation with parents to kind of talk to them about that their kid might be at risk for dying or, might overdose and be at risk for death. Parents, it's hard to think about that with your kid. And so the language we've been using with families is, I like to talk to all families about how to recognize and respond to an opiate overdose. Really hope that you'll never need to use this information, but want to make sure that you're prepared just in case. And so trying to kind of normalize it, and hopefully with FDA approval of naloxone to be over the counter, that's also helping to kind of normalize or destigmatize this is an important medication that everyone be accessing and have. It's always good. You don't expect to ingest peanuts, but you still carry epinephrine with you, right? But for some reason, people don't think about naloxone in the same way. Well, for clear reasons, stigma, but. So as we end and kind of think about this information in totality, so we've been talking about youth with substance use disorders. Substance use disorders and psychiatric disorders commonly co-occur in youth. And we need to really continue to improve our understanding of the relationship between these two disorders to identify opportunities for prevention, harm reduction, and then, really work to try to improve treatment outcomes. So thank you guys for your attention, and excited to answer questions. So.
Can I just ask for a quick clarification? I think when you were talking about ADHD as a risk factor, I think you misspoke and said that having ADHD decreased risk. I think it's or treatment of ADHD. Just clarify.
Decrease it. Yeah. So treatment of ADHD decreases your risk for developing a substance use disorder. Sorry if I was talking fast and misspoke. So having ADHD increases your risk of a substance use disorder. Treatment of ADHD decreases your risk of a substance use disorder. So
Thank you. Yeah, that's what I was hoping.
Important clarification.
I want to thank you for sharing your important work, and especially this message about co-occurrence and integrating care. And one question that came to mind, I was so interested in the comorbidities and what sort of puts youth at risk for substance use disorders. And one piece I was wondering about, if you might be able to speak to, is trauma and post-traumatic stress, and also how you think about integrating that into care when these youth are really in an unstable place when they're coming to you.
Yeah, that's a great point. We know that, there's PTSD is a very common comorbidity, and having a history of exposure to trauma is very common among individuals who develop a substance use disorder. And so as we think about treatment, we really want to be providing trauma-informed care. I worry that that's become a little bit of like a catchphrase, and so really want to make sure that people are really thoughtful as they do that. And how that manifests in my clinical practice is often one thing that's really important for trauma-informed care is providing choices and choice. And so as a kid's coming into clinic, and also being really clear about, kind of the structure of an appointment. And so I'm very clear about nice to meet you, kind of here, this is what kind of why we're meeting today. This is what what we'll cover. And then giving them choices in terms of what they want to talk about first. And then also just, resetting expectations for the appointment. So I've recently had, just last week in clinic, met with a youth who had been incarcerated from age 18 to 22, and he was, just got out of jail a month prior. And so he came in, and you could just tell from the get-go that he didn't really trust me, or does not trust care providers or systems in general. And so, I have my template with all these boxes that I want to check off, and I just, in those kind of settings, often have to take a step back and, make sure that I'm addressing acute risk in terms of suicidality, psychosis, and whatnot, but then just really kind of make a note of the things I'm going to need to come back to and focus on supporting him and coming back to the appointment. And then I think being flexible. So he had been started on bupropion immediate release by a provider prior to meeting with me. And so I was, working to get him on extended release and prescribed extended release, and, talked about it's easier to take once a day. There is a kind of likability effect with immediate release bupropion. And then this week I've been getting lots of calls that he really doesn't like the bupropion immediate release, and, or extended release, wants to switch back to the immediate release. And so I've been trying to help get support from the team to kind of reinforce the message of let's give it a 2-week trial at least. I'm going to see him in 2 weeks, and but talk to them also about that if kind of this is going to be the thing that leads to him not coming back to see me at all, that this is not the hill to die on. And I will we can do that immediate release and just closely monitor for misuse and monitor his response. And so I think just really being flexible as we think about youth who've had a lot of system trauma. And, we, I think, often have rigid rules in our minds sometimes around medications, and to really think about kind of being flexible and patient-centered. So it's kind of a long response, but thank you for the question.
Thank you for all of the local resources too. I know about that high school in Queen Anne, but that's very exciting. My question is going back to the familial risk study. And I just wondered, were you able to include any children or families impacted by adoption or foster care, or was it all biological families?
These were all biological families.
Okay.
So, yeah.
Did your team talk at all about how that might impact results, or any follow-up for kids that were in care at all?
But they were all recruited long before I had access to the data set.
That's true. Yeah, you mentioned it was a larger data set,
and then they had been followed over for 10 years. But I think
Gotcha.
it kind of, as we think about the results, that it's kind of a plan, I think because they were all biologically related, that's, we're looking at the familial relationship, which has an implied kind of genetic, kind of gives us an inference of the genetic relationship. But yeah,
Thank you.
Yeah. Okay. I have a couple questions from the chat. So this question I'm going to start with is a very nice follow-up to the kind of the conversation about how do you stay in touch with kids who are at risk of overdose who are using alone. So this person is wondering, is there any work being done on peer-to-peer interventions on risk reduction? So they say specifically thinking about the phone line, I wonder if video calls with peers would be more acceptable, or active texting to help teens avoid using alone.
yeah, that's a great question. And some of these phone lines are set up to kind of text. So it's a little bit less intrusive than having someone on the phone with you that you don't know. So, but I, informally in clinic, before we had this phone line available, would talk to them about can you at least let somebody know that you're using alone, and so that they can kind of check up on you. And do think that that's important kind of avenue. I do wonder about video though, because most of my kids in clinic do not want to meet with me on video. So I'm like looking at the ceiling, or kind of have to really do a lot of MI to get them to turn the camera on. But I imagine it might be different with their peers. But yeah, I think kind of really trying to, peers are so important for adolescents, and that would be a helpful intervention. Good to think about. So.
Yeah, thank you. Carol, I do have one more. Okay, yeah. So, another question, which probably has all sorts of, broad implications, is what tips do you have for working with families for which the parents also have a substance use disorder?
It's a great question. And often those parents don't come into care. So, in the clinic I was working at, where we often had kind of families with both parents in the same household, often the parent that was struggling with substance use wouldn't kind of come in for appointments, or it was hard to kind of access them. And so we would often be working with the parent that was in the office. And I think trying to trying to be as non-judgmental as you can. And I think with younger adolescents too, it does create this issue of kind of, is there a role for reporting? And it gets really complicated, and just have found that it's really hard to engage those families and kids in care. But that, to try to approach it from a non-judgmental perspective, and then to also, at our hospital, which you guys probably do too, have a child protection team that you can consult with around tricky cases. And so would just say, like, always consulting the child protection team, because often you end up being aligned with either the parent or the kid. It's impossible, it's really hard to be neutral. And so making sure that you're talking about these cases with consultation is really important as you navigate whether you need to involve Department of Children and Families. So.
Well, thank you very much. You're shining a light on a topic that's of critical relevance, and frankly, on the other hand, I'd have to say we're really at a stage of infancy in terms of the ability to provide evidence-based interventions for this population. So it's just hugely important to be able to think and talk about this. And you have some information or perspective about what goes on around here. But I would say most of the time, we really don't know what to do, to be honest with you. We have injected it into our training program. And so there's a regular opportunity for fellows to have engagement with these kids. Our program director is also certified in addictions. And so it's a happy marriage in that respect to be able to get to see these kids. But I don't think our fellows, or frankly our faculty, walk away or have a skill set about being able to effectively treat these youngsters yet. There is an initiative about being able to provide acute interventions. People are encouraged to carry antidotes and stuff like that here. So it just, particularly with the fentanyl crisis, just sort of highlights something that's been there for a long time. I did have a couple of comments though about what you said, and I've been here for a long time, and I've talked to Tim Willens for 40 years about some of these things.
Yes,
so it's
several of his colleagues here.
It's not a small body of perspective about it. I'd have to say I don't think there's much evidence about ADHD treatment doing anything one way or the other. And my own perspective is that there isn't a signal that it hurts.
Yeah, that's the clearest.
I think that's probably a more parsimonious interpretation of a big body of data. I know Tim has some data that says maybe it helps in the short term, but if you look at 30 years of work by Manuz and others, not so clear. Early treatment in mice doesn't make the mice go wild, and maybe it doesn't make kids go wild. So but I think the pertinent question is more practically, if you've got a kid with ADHD, so there's one question. If you've got a kid with ADHD who needs stimulants, when do you treat them? Do you treat them all the way through when they've developed substance use? Do they have to be clean and sober for a day or a week or a month before you can intervene? So, and there's some data that say maybe you can treat them. Other people are more cautious about it. Just one
Yeah.
Why don't you respond to that? And then I
My
have-
executive question isn't
Yeah,
strong enough
so
to kind of
just-
hold on
yeah.
to two questions. So I'll respond to that question. I
Yeah,
think
yeah.
you do have, I mean, I did kind of simplify and kind of probably biased my response, that the studies, that it's been most looked at in terms of what's the impact of medication treatment for ADHD. The studies have shown kind of no effect or decreased risk, or there's no increased risk,
Right.
which is, even though I misspoke. So, which is reassuring and positive.
Yep.
Some of the work that Tim has done with Sean McKee from using the National Survey of Use and Health has shown that earlier treatment and consistent treatment, starting at age 9 through adolescence, decreases risk such that they're not at elevated risk for substance use disorder. And so I think kind of early and consistent treatment can be important. And then it's what happens when they develop a substance use disorder. We have, a lot of data from adults, and then one study from Paula Riggs, who, did a large study looking at methylphenidate versus placebo, and then a study with atomoxetine. And it's, for Paula's study, these were kids largely using alcohol who had an alcohol and cannabis use disorder. They were treated with up to methylphenidate 72 milligrams per day versus placebo. Everyone received therapy and didn't see a difference between groups over the course of the study. Although if you look at parent ratings, so both groups improved, but if you look at parent ratings, the group randomized to methylphenidate did improve more than placebo based on parent perspective of ADHD symptoms. Reassuring from all these studies that have looked at treating ADHD when there's a current active substance use disorder is that there aren't kind of worse outcomes. So people don't get worse from their substance use disorder, doesn't get worse if they're using substances and have both and are treated with a stimulant. That being said, these are, randomized controlled trials where people are seen weekly. So would say that if you are treating someone, if you do kind of trial treatment for someone with ADHD and who's currently using substances, it's important to see them frequently, maybe not weekly, but every other week initially, to see how they're responding. Involve somebody else in holding the medication to make sure that they take it as prescribed. And then if it's not effective, to not continue it, right? Like, so, and then I think, clinically for kids that are using cannabis, like every day, all day long, where like there are some kids that use it really all day long. I'm not sure that stimulant treatment is going to be very impactful for their ADHD. It might make them more alert a little bit, but the bigger issue impacting their focus and concentration and academic performance is their all day long cannabis use. And so let's try to kind of address that and kind of see some changes or improvement before introducing stimulant treatment. But because I think sometimes they end up on a really high dose of the stimulant because someone's been trying to kind of treat through the substance use, and then they have side effects. And so I often actually spend a lot of my time too trying to get young adult men to take their stimulant medication that are in substance use disorder treatment with me, but they've had negative experiences with side effects when they were younger, and had one that was had been on pretty high dose methylphenidate while he had been using substances very heavily earlier in his life, was on break from college because of his substance use, had stopped, didn't want to start taking any ADHD medication again because of those negative side effects, but was really struggling to like come to appointments on time, be attentive during group. And so got him to retrial at a lower dose, and he didn't need such a high dose. And he was like, oh, this is doable. This isn't such a bad medication. But had just been, I think, on a much higher dose because he was using cannabis all day long. And someone was trying to kind of treat through that. But so that's my long response.
Well, but I think it's a long question.
Yeah.
So it begs a long response. And I think the net result around here is that some people, I've got some adult colleagues, I don't know if you know Rick Reese, he's a longitudinal substance use investigator around here, and he's quite comfortable with treating adult patients with active substance use circumstances with stimulants, and me not so much. And so I think there's just personal variability with the ADHD question. The other comment that I had about your preliminary study about quetiapine is that it's interesting and at the same time questionable. I think it's low doses of quetiapine. There's debates between Seattle bipolar and Boston bipolar, which we're not going to talk about today.
We're not going to talk about this today.
No, we're not.
That's
I'm
like
not
2 more
going
grand
there.
rounds,
Unless
so.
you want to talk about it, we're not going to discuss that right here. Except to say that in the face of substance abuse, irritability is a common theme when there's mood dysregulation. And so is there a role there in that nexus for an atypical antipsychotic, or particularly quetiapine? I think this is like a preliminary interesting as a result of it, not to discard it, but at the same time, not to endorse it as the sort of standard of care. So it's an observation, and you can comment, and thank you again for presenting today. So
Yeah, it's definitely not a definitive study, and I think that it's tricky. How do you assess what's a symptom of mania versus kind of this is something related to substance use when you do YMRS, and it's tricky. So, but definitely. But I think treating irritability can be important in terms of helping engagement and treatment, but really do need, I think we need to kind of start looking at these larger electronic health record databases or kind of medical claims databases at this question, because this hasn't been, we've just kind of been sitting with this literature of one randomized controlled trial published 25 years ago and not kind of looking at other ways to try to answer this question. And so I'm not going to try to recruit for a randomized control trial again, but I'm hopeful that we could, try to maybe look at this question using, in a claims database or with all the caveats and complications associated with kind of analyses with those. But and I think your first comments about kind of people not feeling comfortable with substance use disorders, it does there just many challenges, and I think one of those is that often how people have been treated in different systems. So, there's been Department of Mental Health and Department of Public Health, and you couldn't have both. So you could either to kind of be in treatment programs that are funded by DPH, or be in treatment programs that are more kind of within behavioral health, and that both systems haven't done a great job in treating the co-occurring disorder. And so for people in power, I think trying to advocate for better integration of these kind of funding resources and systems to try to kind of do a better job of treating these kids and help people feel, because it just ends up being like this other, right? I mean, you leave training and you're not perfectly comfortable with treating like all disorders, but there's something about, that the stigma associated with substance use disorders, I think that people are just feel a little bit paralyzed in terms of trying to kind of try and get supervision around it, or, but we do have a lot of resources through the American Academy of Child and Adolescent Psychiatry. And so would encourage any trainees or kind of faculty members or staff who are interested in joining our calls to join. And a lot of kind of training resources available through ACAP, the American Academy of Addiction Psychiatry, ACAM, and then the Provider Clinical Support System, which is a funded initiative to kind of increase education and educational resources about treating substance use disorders. And Dr. Rees and Dr. Saxon are both really involved in those efforts. So you guys have a good cohort here in Seattle. Kind of jealous, but wonderful colleagues here.
Hey, Amy. Thanks for the shout out. That was an excellent presentation. So I think one of my questions I think maybe partially just answered, but just to check my sort of understanding on your perspective, perhaps not in psychiatry, but I've had other colleagues want to withhold psychiatric medications, not just ADHD, but for the other comorbidities until a youth is clean. And it sounds like your perspective is not to do that. And so wanting to check that assumption, number one.
So yeah, and I think one thing though is to gather really good history to try to tease apart it a little bit, because opiate withdrawal is incredibly anxiety provoking. And so if you've ever sat with someone in opiate withdrawal, they're like, just give me Ativan and I'll stop my opiates, everything will be fine. And so, sometimes some of the psychiatric symptoms are really more clearly related to substance kind of withdrawal or intoxication. And in those scenarios, really kind of, okay, here you wanting an Ativan, and let's talk about buprenorphine. So let's talk about treating your opiate withdrawal symptoms. So just to clarify that piece, but where it does seem to be truly a co-occurring disorder, from my clinical, we're really missing we don't have a lot of evidence in this space, especially for kids that don't withhold treatment. I think about the kind of how the medications I'm prescribing might interact with the substances they're taking, but don't kind of withhold treatment.
Thank you. I think there's one other person asked a question, so I can ask you my second question offline.
Okay.
Hi, thanks for doing this research. I have a question about resilience factors, perhaps beyond access to treatment. But I'm thinking about that slide at the beginning part of your show, of your talk, that showed that a third of high school 12th graders had used some kind of substance, which is a huge chunk of the normal part of the bell curve. And what is it about the people that don't go on to then have regular use and the people that don't go on to have problematic regular use? Are some of those protective factors modifiable, and can we use that to educate people earlier on?
Yeah, I mean, I think that the biggest protective factor is if you have pro-social kind of activities that you can do that don't involve substance use, like kids will do them, but they just really often don't have that option. It can be really hard to find an activity that, in college campuses, nearly impossible to find an activity on the weekends that doesn't involve substance use. And so as we kind of think about what can we be doing as a community, I think there is really a moral mandate for us to all be thinking about in our daily lives, like how can we create have opportunities for kids to have more pro-social, positive experiences that don't involve substance use. So for my son's school, there weren't a lot of parents volunteering for the senior school dance or something. And I was like, my child's an elementary school student. And I was like, I'm happy to volunteer. Like, I want to make sure that these seniors, have opportunities to do something fun that doesn't involve substance use. And so for all of us to be thinking about advocating and supporting those kind of activities in our communities. And one of the nice parts that you guys have in Seattle is we were talking about the Recovery High School is linked to something called alternative peer groups, which is different than mutual help groups such as AA or NA, and it's just really focused on having fun activities on Friday nights, Saturdays, the weekends for students for kids with a substance use disorder that don't involve substances, and helping them to have those positive experiences. So.
Such an important point. Thank you. And I want to just thank you for the wonderful talk and for the research you're doing, and just appreciate the need for more research and clinical expertise in this area. So we appreciate it. I do also want to let people know that I think the starting point for the Research Development Day is back out in the foyer here. So we'll say thank you to Dr. Ewell and transition to the Research Development Day.
Thank you for having me.